Hi, good day and good morning. I'm Sherry Lang, Deputy Chief Medical Officer with the Centers for Medicare and Medicaid Services, and it is my honor to welcome you to our discussion on the future of American healthcare workforce. During this session, we'll be touching upon issues and dynamics that impact the healthcare workforce, and who better to share their insights than our all-star panel of clinicians. We in all are aiming to arrive at and share information and solutions that are translatable and transferable in our journey towards a high value learning healthcare system. So with that, I'm sincerely pleased to introduce our four panelists. This is a fantastic group and I'm so delighted to have them here with me today. And as a reminder, you can access their full bios on our conference website. So, very briefly, we are joined by Dr. Lottie Derby, a Senior Associate Dean of Faculty and Chief Wellbeing Officer at the University of Colorado School of Medicine, and is a thought leader in the issues of clinician burnout and also engagement. We're also joined by Dr. Christine Sinsky, who is the Vice President of Professional Satisfaction at the American Medical Association. She leads initiatives at the AMA to improve opportunities for joy, purpose, and meaning in work for physicians and their teams. We're also joined by Catherine Spates, the Executive Vice President for Public Policy and Government Relations at the Joint Commission. Before she began her federal career, her government career, and legal career, she spent many years in clinical care as a nurse and an acute care nurse practitioner. And last but not least, we're joined by Dr. Ashby Wolf, a board certified family physician who currently serves as the Chief Medical Officer of the Centers for Medicare and Medicaid Services in the Seattle and San Francisco office. And Dr. Wolf's focus has been on the implementation of Medicare, Medicaid policy across the Western US and the Pacific territories. So let's get started. So the first question really is directed to Christine, um, Lottie. Also, any of our panelists can feel free to opine, but beginning with Christine. Back in 2019, a study published in the Annals of Internal Medicine that both you and Dr. Derby contributed to really estimated that approximately 4.6 billion in costs related to physician turnover and reduced clinical hours is attributed to burnout each year in the United States. We know that burnout is not just limited to physicians and is experienced by all healthcare workers and healthcare providers. So the numbers associated with these costs could actually be much higher, much more substantial. Christine, can you start by speaking about some of the different ways healthcare worker burnout costs in our system, what the magnitude might be, and what kind of investments can and should be made by institutions to mitigate burnout, improve resiliency, and also curtail some of these high costs? Turn to you, Christine.
Sure. Thanks so much, Dr. Ling. It's such an important question that deserves close attention. The bottom line is that healthcare worker burnout is expensive. We have a $4 trillion industry that's underperforming, and it's underperforming in part because of pervasive healthcare workforce burnout. Our latest data showed that 63% of physicians are experiencing at least one symptom of burnout. Work that Dr. Derby and others have done in the nursing and other healthcare workforce show that this is in the 45 to 56% in nurses and others. And we know that this is expensive. When physicians are burned out, they're more than twice as likely to leave their organization, and that's really costly. And it costs between $800,000 to $1.3 million to replace a single physician. That's the cost to the organization. But it's also costly to patients and payers because turnover, when physicians leave an organization, that erodes continuity of care, and that's disruptive to patient care. And it leads to patients getting care at more expensive sites of care. It leads to patients getting more testing than they might otherwise have gotten from their personal physician. And so we know that it costs nearly $90,000 in excess healthcare expenditures every year when when a physician leaves their practice. And so adding all that up, it's really expensive. So what can be done? There's a lot that can be done. And I think it's really important that we do this. And one more reason that it's important, we did a study that was just published that showed that 40% of physicians plan to reduce their clinical effort. This is double what it was in 2014. And if we add that to the physicians who intend to leave, and we know about a third of physicians who say they will leave or will reduce will do so, that means we can anticipate losing 20,000 physicians due to burnout every year. And that's the exact same number that we graduate every year as new medical students. So at the far end, we're losing physicians because of burnout and reducing their clinical effort time, going to part-time. And that's the same number that we're training every year. And so we're falling behind, if you will. So what can be done? We know that we spend much more time on the electronic health record in the US than our physician colleagues in other countries. Our notes are 4 times as long, and the work that CMS did to change the evaluation and management guidelines was really, really important. One of the most important policy changes I've seen in my lifetime. We also spend twice as much time on orders as our colleagues in other countries. And I think we have an opportunity to be really explicit about team order entry being an optimal workflow and to reduce any of the barriers, reduce any prohibitions against verbal orders, as an example. Lots more that can be done that I'm happy to add in, but let me stop there and let you continue the conversation.
Terrific. Thank you for those insights and tying these bits of evidence together in translating in terms that actually are very tangible for us. So thank you. Dr. Derby, did you want to add to Dr. Sinski's comments? And keep in mind that, you know, there have been several proposals, guidance, policies that really have been aimed at reducing administrative burden, simplification, streamlining, including some of the applications of billing codes. So any additional thoughts to add to Dr. Sinski's remarks to start?
Yeah, thanks a lot, Dr. Lynn. So just a couple of things. As Dr. Sinski mentioned, you know, this is an expensive problem for the healthcare system because doctors, nurses, other members of the healthcare team are, you know, quitting or reducing their clinical FTE. In addition to that, when you have burnt out healthcare workers, we deliver suboptimal care. We deliver more expensive care. So there's multiple meta-analysis, big studies that have really shown that burnout impacts quality in a variety of different ways. If you just look at surgeons, for example, if they're burnt out, they're twice as likely to have committed a major medical error. They're twice as likely to be involved in medical malpractice litigation suits. The level of burnout in nurses and doctors in the ICU is an independent predictor of patient mortality. The level of burnout in nurses is an independent predictor of hospital-associated infections, right? So it's not only sort of productivity and retention and turnover, but it's also very much quality and safety, and how that, you know, obviously causes a lot of suffering to patients and families and drives up healthcare costs in addition. And with respect to strategies, you're right, Dr. Lane. A lot has been talked about. There's the National Academy of Medicine consensus study report that has a variety of suggestions and strategies built on the evidence that we can talk about. There's also the U.S. Surgeon General's report focused on healthcare worker burnout and very overlapping, very similar recommendations and strategies. And certainly a big part of it is, how do we reduce the workload, right? So the job demands are simply too high for our healthcare workforce, and reducing administrative burden is one important piece of the puzzle. And as Chris mentioned, I'm a primary care doctor, and I'm very thankful for the fact that my notes can now be shorter. They can be very much focused on going with the assessment and the plan, and then below that having the subjective objective component, and that has been helpful. The other piece in primary care practice is, we spend at least an hour a day, entering orders into the system. And I think other people could probably do that just as well, if not better than me, and save me an hour where I could see additional patients during the day, increasing access to care. So certainly there's been improvements in the administrative burdens, at least for physicians, and we have, there's more room to go for sure.
Excellent. Thank you. And Dr. Derby, if you could also continue by perhaps addressing, the issue of translation, right? The fidelity of translating what the intents are, what the intended purpose of the policies are. And, sometimes it's clearly with high fidelity translated into points of care, and other times it's a little less clear. And so any thoughts you might have of improving the translation from intent into action, we would welcome your thoughts to add to.
Yeah, I think one point there, Dr. Lynn, as Dr. Sinskey brought up, was, for example, around the coding changes, the documentation changes, right? So, there were these really consequential policy changes, about what we actually needed to document in our notes, particularly for E&M codes, and really huge step forward. But when we look at sort of studies that have pulled, has the length of the notes actually changed, right? When we look at what we call electronic health record audit log data, we see sort of disappointment, right? And that, wow, this big policy change happened, yet we don't really see substantial decrease in the amount of time physicians are spending, writing notes in the outpatient setting. We don't really see that these notes that Dr. Zinsky already highlighted are much longer in the United States than they are, in Europe. We don't really see them shrinking. And why is that, right? Why hasn't it translated? And there's probably a number of different reasons. One is, frankly, you have burnt out, overloaded, overworked physicians who cannot learn one more thing or do one more thing because they are just cognitively completely tapped out. So the education piece hasn't gotten to them, and they're still, stuck in sort of the 1997, sort of rules, right? The other piece that we think is playing a piece is that there's concern that payers outside of CMS may not accept the shorter notes. So that's also a piece of the puzzle. And then I think there are, as Dr. Zinsky has written about, these sort of persistent regulatory myths. So Dr. Berwick, a number of years ago, did a big study with over 24 healthcare organizations and simply asked if you could break or change one rule to be able to sort of improve the service of care that was delivered to patients, the experience by staff, healthcare workers in the hospital, what rule would you want to break? And what's really fascinating is like almost 80% of those rules that were identified actually weren't rules at all. Like they couldn't find them at all. Only 22% of the rules that were identified as sort of quote unquote getting in the way of patient care or causing a lot of burden to healthcare workers were actually statutory and regulatory requirements, right? So that goes to really speak to the fact that we need some more effort around regulatory myth busting to get sort of everybody really up to speed and understanding all the way from the physicians, the nurse practitioners, all the clinicians who are documenting episodes of care using EMS coding, all the way to the coding and compliance office within healthcare organizations. We all need to sort of get on the same page and really move toward using kind of this note format, right, which starts with the assessment and the plan, and rather than the traditional note, so we can move forward with actually reaping the benefits, right, of less documentation requirements.
Terrific point. And I like that myth busting. And Chris, do you have other thoughts? I know you want to.
Well,
let's go.
Yeah,
Go.
no, I just wanted to dovetail on what Dr. Derby said, in that I do believe a lot of the myths may start in federal language from the Joint Commission or from CMS, but then they're enabled by the electronic health record, and then they're exacerbated by overinterpretation at the local level because organizations don't want to be out of compliance. So just to be safe, let's do this. And doing that is actually adding to the burden and making care less safe. And I thought I would just share something that happened to me on last Friday at a site visit to an academic medical center where they'd done exactly what Dr. Derby just described. They changed the template so that it was APSO, assessment plan, then subjective objective, and subjective objective collapsed. So when you were looking at multiple notes, you only saw assessment and plan. And they were able to reduce the number of characters in each note by 1,000 characters and the time spent on each note by a minute. Now, you might say that doesn't sound like much, but if you're seeing 15 or 20 patients a day, that's 15 to 20 minutes. And I think that we just have to keep chipping away at every one of these sources of friction and pain that keep us from doing the work we're trained to do. And so I think that E&M coding change was really great. And we don't know altogether why things didn't drop, but I think changing the template helps. Maybe the notes are better. We have another study that's not yet been published that shows that physicians feel the burden of the note is less, a qualitative study that we've done. And I think that points to, well, maybe we're spending more time on the things that matter, using the chart as a source of communication as opposed to as a source of billing justification.
I think that sums it up very well, and being able to reduce or improve the signal to noise, both for at the point of entry of the information, but also being able to read and find the gold, right, in the notes before you from the sea of words and letters that appear on the screen. So I think terrific insights and thoughtful suggestions on how we move forward. So a question for Catherine then. So in 2022, the Joint Commission issued new and revised workforce violence prevention standards for hospitals and critical access hospitals. So the context here is, when things are bad, when burned out and demoralization just permeates in work environments, even worse things can happen. So since that time, have there been data emerging that show where we are in the healthcare worker environment as far as experiencing violence and mitigating risk of violence, and how this all ties into clinician burnout, or said in the positive way, building resilience? What are your thoughts, and what are hospitals currently doing? What could they do to take action here? To you, Catherine.
Yes. Yeah. First, thank you, Dr. Lang, for having me here today, and thank you for the question. The statistics around workplace violence, I mean, they're really heartbreaking, and this just absolutely should not be happening to healthcare workers who go to work right every day to provide the best care that they intend to provide. Why they chose the professions they have chosen, they really, should not be facing this. As a nurse myself, I really know these statistics firsthand. And again, it's really heartbreaking. And I know this is happening to our colleagues. So one thing that we have done at the Joint Commission to really address workplace violence, as you mentioned, we implemented workplace violence prevention standards in January of 2022. And these requirements is what they really do is they require hospitals to follow a set of standards aimed to prevent workplace violence. And the standards include everything from establishing a process to evaluate and report safety incidents related to workplace violence. They require hospitals to implement a workplace violence prevention program. And one thing they do that I think is really critical and is important is, and it gets to your point about burnout, is that it includes include a process to follow up and support the victims, which I think is critical and something that I don't think we think about often is, really following up with your colleagues and in the healthcare workforce that experience these incidents and, make sure just a simple check-in, how are you doing? And that's built into our requirements, so it's critical. The standards also require staff to receive workplace violence prevention training and education and other resources. And it also they also include de-escalation skills as part of that training, which I think is also critical. And we have tons of resources related to workplace violence because of our standards. And this is just, one step in the process, but I think something that's going to hopefully help address some of these statistics that we're seeing out there.
Excellent. And in addition, perhaps you could also say a little bit about this in that, the collateral damage, as it were, can be pretty substantial, right? One staff member affected is not one staff member affected.
Mm-hmm.
So, how do we utilize that dynamic for maximal protection and prevention as well as healing? Any thoughts that you might have?
Yeah, I mean, first thing, just with regards to the topic of workplace violence, I think, and getting to that healing point, the fact that we're even talking about it, because when I started in healthcare over 25 years ago, we weren't even talking about workplace violence. And I think the fact that we're not only are we talking about workplace violence prevention, but we're also implementing actions to address it. I think a few years ago we were talking about it, but now we're actually implementing steps to hopefully create a forum where healthcare workers feel like they can convene and talk about the various things that they're experiencing in their day in and day out of work.
Excellent. And Dr. Derby, perhaps there's also the dynamic of the brunt of that's brought to bear on the workforce, but sometimes that comes from not only visitors but patients, families, when things are just not going well. And any other thoughts there?
Yeah, just sort of piggybacking on what Catherine was just saying, workplace violence has become, it seems to me, more and more of an issue, right? So having practiced now for a couple of decades, the culture has changed. And, not only is there seemingly more workplace violence, but there's also there seems to be, more mistreatment, discrimination from patients, families, and visitors, sort of toward healthcare workers. In one of our big studies of U.S. physicians conducted across the United States, all specialties, about 20 to 30% of our physicians really reported being mistreated, harassed by patients, families, and visitors, either racist remarks, sexist remarks, or even frankly being told, you can't care for me, or you can't care for my loved one because of a particular demographic or attribute, that's apparent to the patient, family, and the visitor. And that, to me, that's really heartbreaking. It's obviously happening more to women physicians, to racial and ethnic minority physicians, and also to our physicians really working in the front line, particularly in the emergency department. And this is where we need, also sort of really rigorous policies and procedures in place within organizations so that we as healthcare workers know how to stand up, right? Do that bystander part to protect our colleagues, our friends, when this does happen in the work environment. If it happens to us, that we know that we can, sort of respond, and our employer has our back. So this is sort of another challenge that's really happening in healthcare over the last, 5-6 years or so, is this sort of mistreatment from patients, families, and visitors, and something that we definitely need to address as our part of our strategy, right, to improve the work environment. And I think this sort of piggybacks onto Dr. Sinskey recently had a paper published looking at politicization and sort of, how does sort of all the politics, around COVID, around vaccinations, immunizations, et cetera, sort of really also had an impact on the healthcare workforce. I don't know, Dr. Sinskey, do you want to make any sort of comments about that piece? It's connected, I feel.
It is.
Yeah, I think so too. I'll be happy to kind of give the top line of that. So we
Right.
found that almost 3/4 of physicians who are COVID facing, so ICU, ER, hospitalists, and primary care docs who see COVID patients in the ambulatory setting, almost 3/4 of them were burned out, so higher than the general population of physicians. And 90% had indicated that they had increased stress because of conversations around masking, around vaccines, around unapproved therapies. And half of these physicians experienced moral distress. 20% felt their integrity was compromised. And I think this erosion of empathy and compassion and this development of professionally conflicting emotions that physicians naturally feel in this really high pressured environment where politics has been so intrusive into the exam room is part of the environment in which physicians work right now and is a contributor to the overall occupational distress of burnout.
Yeah, terrific points. Very complex dynamics, but by delineating these issues, and it creates with us awareness and sensitivity, but also thinking about what are the opportunities for us to address this, across the board. This is, many of us practice in one setting over the other, but it is all related, and we are really, one workforce that has faced challenging times. And so as we recover and as we really stand up new thoughts and opportunities to improve patient care, this is a tremendous opportunity. So really appreciate your remarks. And thinking about the future starts now, of course, but when we think about all that we have been discussing today, the costs, the financial costs, the monetary cognitive stresses, the administrative burdens, the environment that our clinicians and health providers are living in, practicing in, I'm going to turn to Dr. Wolf to share, what your thoughts are. How do we prepare the next generation? How do we entice the next generation to really take up, take the baton and prepare them optimally so we have a better future state? Ashby, what are your thoughts?
Thanks so much, Sherry. And it's really a pleasure to be here. I think, care delivery, even in an efficient and sort of less burdensome environment, can be very challenging. It's messy. There's not a lot of black and white situations. And, as we work on reducing burden, addressing burnout, many of the efforts that have been described here, I think the challenge for CMS is to couple these efforts with enhancing capacity and supporting quality of care, particularly for our most vulnerable members of the population, and identifying the joys that come with caring for our most vulnerable and complex patients, in addition to being realistic about the challenges, is incredibly important. In my capacity, I have the privilege of speaking with clinicians who practice in a wide variety of settings across different environments here in the West. They have strong perspectives on how CMS should be moving forward in the burden reduction and workforce space. And what's interesting is, in addition to the concerns identified by my fellow panelists, feedback that we've continued to hear pretty consistently is a desire for strong support of team-based care and support for all that comes with the management and coordination of care for complex patients, and increasingly complex patients as our generations age. And this is accompanied by very strong interest in ensuring that there is adequate reimbursement for clinicians who are spending the time to coordinate and communicate with patients, confronting those burdens that we've talked about in order to address and provide an adequate treatment plan. And clearly, documentation is at the top of mind. It's at the top of mind of our trainees, as well as our attending physicians and other clinicians. In fact, a family physician I spoke with yesterday in Clallam County, Washington, responded immediately when asked what his number one challenge is: documentation burden. And this effort has clearly been researched. There's multiple published studies. In fact, one study published in 2022 sort of revisited how much time does it take the average physician to provide all the recommended preventive, acute, chronic care to their patient population in sort of an average panel size. And the study came up with a number of 26 hours a day is what is needed. But what was interesting about the study is that it also identified a potential solution to reduce some of those burdens associated with providing all that recommended care. And it was practicing in a team-based model. And there was an analysis done by this study that showed that the hours the clinicians needed to spend providing the care, documenting the care, coordinating that care went from 26 hours to 9 hours per day. Still high, but far better than if the clinician were shouldering that burden alone. And so while burnout in particular is highly complicated, burden's a significant contributor, valuing the time and the resources that clinicians are using to care for their complex patients in a team-based setting seems to be a potential solution, and something that for upcoming generations of trainees and clinicians is really critically important. Many of you are probably aware that for the coming calendar year, CMS is actually working to address this by finalizing policies that support reimbursement for clinicians coordinating with community-based staff, such as community health workers and peer navigators. But also, I think something that's really important is that clinicians can't be successful if their patient, their family members, their caregivers are confronted with their own burdens, and those burdens get in the way of their relationship with the healthcare team. And so ensuring that the patient is a part of that team is really critical. Nowhere is this perhaps more visible than in caring for our patients with dementia. Their care is often fragmented. It's very difficult to engage at times with the patient themselves. And so there's a great deal of reliance on family members or others who are serving in that caregiver role. And so again, CMS is working to address this in the coming calendar year with reimbursement policy to support the time and resources that it takes to actually help to train caregivers to support their loved one or their charge for those patients who have dementia or other complex illnesses. And so that approach in the spirit of team-based care, I think, can really be valuable in supporting the next generation and to trying to identify and value the joy that comes with managing those complex patients. And it's really a critical part of CMS efforts to supporting the workforce, reducing burden, and ensuring that our clinicians are there to care for our most complex beneficiaries.
Terrific. And Ashby, maybe you could also say, from your perspective, you have an opportunity to see how things may differ across the country, right? And there are certain challenges that are notable, rural settings as well. I mean, I understand we're trying to solve it all, but we need to solve it all, and we have to do this and address these issues across the board. But any thoughts you have given this audience, this panel, are we approaching this in the right way? I mean, is there more we should be thinking about, specific peer settings or the dynamics of the region or locality? What are your thoughts there?
Sure. Yeah. So I, as Sherry's alluding to, I help to support the implementation of our CMS programs across the states in the West, which also includes Alaska, the state of Hawaii, and the Pacific Territories. And of course, care for patients in all those settings looks very, very different. But some of the themes that we continue to hear is an emphasis on ensuring that our clinicians have the ability to communicate effectively with each other. And that's something that I think is really critical to, again, kind of supporting the joy in practice that comes with the enthusiasm of our trainees as well. And ensuring that there's a mechanism for that communication, be it virtually, be it in person, is not necessarily completely in CMS's wheelhouse, but it's certainly something that can make or break a beneficiary's experience in our programs and a clinician's joy or discontent in participating in our programs. And so I think that communication is really fundamental, and it looks different depending on where you are, rural, frontier, island communities, or in an urban setting. But it is fundamental to supporting that care experience. And we've heard recently a number of physicians and other clinicians emphasizing that feedback, and really, it doesn't matter which specialty they all comment on the fact that they cannot do this work alone, and that they need the support to be able to effectively communicate with one another in order to ensure the patient's getting the recommended care. So mechanisms CMS can use to encourage and support and value the time and coordination that it takes between clinicians, I think, is also a theme we hear more and more these days as time moves forward.
Excellent. Thank you so much. And thank you for your service. So I think, given our time together is somewhat limited, I do want to just also express my appreciation for your thoughtful remarks, and also ask each of you then, so what is the top development, top opportunity that actually makes you hopeful that we will be able to address these issues and be able to translate the work that we will do together into better patient outcomes, a more resilient workforce, and also open the door for an amazing future for our pipeline clinicians. So, what would be the one thing, that's part A of the question. I know it's a long question, but part B would be, what would be a ask of our audience for them to leave in action, so that as time proceeds, that it will jumpstart them into the solution set. So I will start with Dr. Sinskey, if I may.
Sure, Dr. Lynn, I'm happy to do that. I think answer to part A is the thing that gives me hope, and the thing that I think is important for us to continue to do, and that is to build the evidence base. I think the research in the last 10 years, and particularly in the last 5, around the drivers of burnout, the consequences of burnout, and interventions to improve burnout are giving us good direction on where to go. And I think, like we strive for evidence-based medical practice, we also need to strive for evidence-based regulation. And so I'm hopeful that we can de-implement some of the regulations that have actually not lived up to their expectation, or that may have actually never had a strong evidence base. And again, I might put here the prohibition against verbal orders. I don't think we understand the pervasive waste of time that has created, and that multitasking cognitive burden that's unnecessarily placed on our highest trained individuals. Um, and so I would say that's the research evidence that's given me hope, and I hope we can continue to develop that. And that will help us with things like prior authorization as well, and figuring out where that will best be. And to the stakeholders, well, we have a really broad stakeholder group, I think, represented here. And I think the thing I'd say is whatever your stakeholders' primary objective is, you are more likely to get to it if you consider the well-being of the workforce. And so every decision that you hold up, every decision that you consider at the Joint Commission, at CMS, as a payer, as a health system leader, I would hold it up to, what does this do to the workforce? What does it do to the doability of the work? Because I believe that what our patients want and need, and what our physicians and other healthcare workers want and need, are aligned with what our payers and regulators want. But we have a lot of non-evidence-based sludge that's in the way. So that's what I would say. Thanks so much.
Thank you so much. Dr. Derby?
Those are really great comments. Thanks, Dr. Lynn. And just really echoing on what Dr. Sinskey had to say. I think just to add on that, I'm incredibly hopeful and optimistic. I started doing research in burnout, 20 years ago with Dr. West and Dr. Shanafelt. And when we first started this work, people were like, that's not exist. That's not a problem, right? And then as we've been building the research with Krasinski and other collaborators across the country, people now understand that it is a big problem and it matters. It matters to patients, to families, to the U.S. healthcare system, to individual clinicians in so many ways, many of which we've talked about today. And there's lots of things that all of us can do really within our sphere of influence to optimize the work environment, to continue to work on addressing kind of the administrative burden like we've highlighted today with notes and orders and all of those other pieces. The prior authorization, certainly very familiar with that as well in my practice. So I'm really hopeful. And I think another real demonstration of just the ability that we have together is if you think about the COVID-19 public health, emergency and how we really allowed for incredible innovation in the telemedicine space, right? That enabled us to get to the remote corners of Colorado to deliver outstanding care to patients who were suffering from, behavioral health concerns or other concerns. And as we move forward, I really would hope that we could continue to work together to, make some of those rules and regulations around telehealth really just permanent. It's a great service to patients. And frankly, a lot of physicians really enjoy it. It gives them a little bit more flexibility and autonomy in their workday. So in terms of all of our listeners, I cling on to the hope, we're working hard. We're trying to build the evidence, as Dr. Sinskey highlighted. And then I encourage everybody to lean in. There's a piece that every one of us can do every day to really help optimize the work environment for ourselves and for our colleagues with the goal of delivering optimal patient care. So thanks, Dr. Lynn, for the opportunity to be part of this session today.
Terrific. And to you, Catherine.
Sure. What really gives me hope, and already we've heard some wonderful remarks, is that we're all working together, and I think that's key because there's so many players involved. Here we are on this panel with great stakeholders, the audience, but also CMS, the Joint Commission. I think it takes everyone. Really, the healthcare ecosystem involves many different stakeholders, many different regulatories, and just the fact that we're all here having this conversation is critical, and making sure that we have the right people at the table. And one thing, that I haven't had the opportunity yet to say, but I just want to mention it, one thing that we're really doing at the Joint Commission is taking a look at our own standards and making sure that what we are serving to and the standards that we have, that they're actually meaningful requirements. And the goal of this process that we've been doing over the last year, and I just want to note that, as a part of this process that we've already eliminated or consolidated over 200 of our standards. And the goal of this is because we really want to have more meaningful requirements. We talk about our workplace violence prevention standards, and it sounds like, oh, an additional requirement, right? But we're also taking away those requirements that don't matter and really implementing requirements that do matter for our healthcare workers. And so, I think what the stakeholders on this call can really do, or part of this conversation, is have the conversations with people like the Joint Commission. We are people, and I heard this on another session earlier already, is that you don't think of the CMS as being people, or the Joint Commission as being people, but we are people and we are clinicians and we understand the issues. So, if you have issue areas out there, please feel free to bring them forward to the Joint Commission, to CMS, or to others that are working on these issues.
Thank you, Catherine. Ashby?
Thank you. Yes, I think for Part A, what inspires me most is actually engaging with our trainees. I have the ability and often the privilege to meet with our physician assistant students across the region, pharmacy interns, resident physicians, et cetera. And I hear their enthusiasm as well as their concerns around the practice of medicine, and they're well aware of some of the challenges we've discussed already, but they remain undeterred. And I think if our trainees can find the enthusiasm for continuing to pursue their education to eventually be able to care for our patients, that inspires me as well, in the clinical and in the policy environment. So that's my answer for Part A, what keeps me going and what gives me hope. And of course, that inspires me to ensure that at CMS, we are really working to create an environment that clinicians want to practice in terms of the regulatory side. And I think for sort of leaving an action, I love that concept of evidence-based regulation and sort of what has not lived up to its promise. Are there priority areas that folks have in the audience that you would like CMS to look at next? What are your priorities for evidence-based regulation? And certainly we know prior authorization is a key top issue, and we're actually working on that at the moment. We know that 42 CFR Part 2 and some of the challenges in sharing information for those with substance use disorder and other conditions is a big challenge. But we would love to hear what other areas CMS should prioritize in terms of our opportunity and our challenge from this panel to do more work in the evidence-based regulation space.
Thank you, Ashby. And thank each of you and all of you who have joined us, committed your time and donated your time to spending the last few minutes with us. I think we have many take-home messages, top-line messages, though I have to say that this conversation has been invigorating, inspiring, very meaningful, and actionable too. So, as Catherine has said, we're people solving problems that affect people, right? And we frame it in terms of healthcare delivery, but this is very much a people thing. So, for any of you in the audience, you clinicians, we would love to hear from you. Please do submit your thoughts, questions, suggestions of what is it that, as Ashby put it, how would we prioritize what we are looking at. We are not only is evidence-based approaches nice to have, but we're actually, through the Evidence Act, we are obliged to refer to, acknowledge, and be mindful of the evidence as it emerges to inform policymaking and program implementation and refinement, and perhaps also, policy, as Christine said, decommissioning, if you would. So I really want to thank all of you for joining us. And just as a reminder, we will be dismissing for a refreshment or lunch break And please do join us again, 12:35 Eastern Time, for the presentation by Dr. Richard Shannon about strategies that Duke Health has adopted to improve work processes that generate better patient outcomes. So thank you all and have a great day.